right. So it is 12 p.m. Eastern, everyone. Good afternoon, everyone. We are going to go ahead and get started with our FMDA Journal Club. I am Dr. Diane Sanders-Cepeda, your host for today. I'm also going to be your presenter, and hopefully everyone can see my screen. I want to talk today about long COVID. And I know in this form, we talked about this a couple of times. I think we had a formal presentation maybe a year ago with myself and Dr. Pamela Scarborough, where we were first discussing long haulers and really sort of enlightening everybody. We also presented, she and I together at our annual Best Care Practices conference, and most recently at the FDANA conference. I think, if you haven't heard me talk about this, then you know that you've been spared probably my obsession around this. And much in the way of the advertisement, it has been much of a rabbit hole. We're just trying to find information around what's happening and how this impacts our patients in our continuum and what we need to be doing about it. That has taken up a lot of time and a lot of energy, but I do think that is something that we really need to wrap our heads around. And with that, I want to start with a case. So there's a 78-year-old woman who was admitted to a SNF for post-acute care. She has been in the facility for about 2 weeks, and it was reported that she's not progressing with therapy, not doing well with physical or occupational therapy. Her family was informed of the potential next steps, which were that if the patient was to remain at the facility, she would have to be a long-term care resident. They could coordinate discharge to home with in-home care, which, I don't often know if our family members understand what that means, but it was home with home health, basically. And the daughter was very upset. She wanted her mother transferred to the acute inpatient rehabilitation facility, which I have abbreviated as an AIR, because the SNF is not treating her mother. And she's upset that this level of care was initially denied. So the background, that person, the daughter had requested an AIR in the hospital, but upon assessment, it was determined that the patient couldn't tolerate that level of rehabilitation. So we get this woman, and the question is, okay, what's going on? What's happening? She has a history of osteoarthritis and hypertension. Her current recent history includes a COVID diagnosis 5 months ago. Since then, she's had muscle weakness and falls in the past 2 months, which led her to be hospitalized. Her daughter states that she was very active before. She would do gardening, walk around the neighborhood, visit with her friends, watch her grandkids, and she needs her mother to get back to that level of functioning. And so she's, as I said before, very upset because she felt that the SNF was not doing anything. When we looked into the case a little bit deeper, it was documented that the patient has had complained of feeling very exhausted for the past 3 months, that she does have shortness of breath when attempting any activity. And her last hospitalization, she was treated for a UTI despite having negative urine cultures. And then upon review of her chart, it was noted that she had post-COVID condition, which was documented by both the physical and occupational therapists who did the assessment. And the question is, what's going on? What is this, and what is this case? So I will say that I feel like I've heard this case now maybe 100 or even 1,000 times. From where I sit, is something that I see a lot. And we'll hit upon this a little bit later as we review some more cases, but just remember that the only documentation about post-COVID was by the physical and the occupational therapist. And that was after reviewing a hefty amount of notes. So, we've defined this before, but just so that everyone is aware, post-acute sequelae of COVID is what the formal name for this condition that we've come to see called long COVID. And when we look at that, that has been recognized, and it really was socialized back in 2020, in the summer of 2020, when people were trying to understand, well, why do I have some persistent symptoms? Why, after 3 months, am I still spiking a temperature, feeling nauseous, having trouble tasting or smelling at times? And long COVID became the term, umbrella term that we use to describe all of the physical and mental health consequences of COVID that was lasting for more than 12 weeks. The challenge, though, has been to really understand why we're seeing this and to understand the physiology. I will say that the World Health Organization did put a definition around post-acute sequelae of COVID that included a history of a probable or confirmed COVID-19 infection, symptoms for 3 months from the onset of COVID that are lasting for at least 2 months and that cannot be explained by an alternative diagnosis. Now, when I've had this conversation with others, the question always comes up, well, our population has multiple comorbidities, and we could probably explain away all of this with in association with some other conditions. So that is something to consider, and I just want us to broaden our differential diagnosis and think about, could this be post-acute sequelae of COVID? What we do know is that when we're looking at active COVID infection, there could be, there are times people who go through what we call the cytokine storm, which is that acute hyperinflammatory response. We know that this is a crucial period, and it has a multi-organ dysfunction where we're seeing and we've seen multi-systems be impacted. So from the respiratory failure that we see with the lungs, kidney failure, GI symptoms, the headaches and impaired consciousness that we see neurologically, every system has been impacted. So we're trying to figure out how does that then translate to being a true pathophysiology. Like, what is the pathophys that is causing these post-acute sequelae of COVID symptoms? One theory is that there is a potential immunopathological mechanism that's underlying this issue. So we're seeing that maybe the immune system is exhausted, maybe there's hidden viral reservoirs or a viral-induced autoimmunity. And a lot of this, this study came out in 2021, but is really the basis of a lot of the studies that we're seeing now in the design, where we're really trying to understand, okay, what are the underlying issues? And taking it from, do we see an imbalance in the neurohormonal system? Is there an imbalance in the immune metabolism? So is it altered microbe? What are we seeing? So when we're looking at that, another study that sort of had great longevity is the ideal of this impact across the different populations, and in thinking about this is maybe caused by an immune pathological response. What happens when we think of the severity of illness? So for those individuals who may have more risk factors, are they more likely to have those lingering symptoms? Is it also impacted by the fact that you had a severe course with the disease? And so this is also one of those frameworks where we're seeing a lot of the studies be based off of, where we're thinking that there is some abnormalities persisting in the immune response possibly hidden viral reservoirs, an imbalance in the neurohormonal system, the renal-angiotensine system, and prolonged chronic inflammation. So a lot of this is the basis of what we're the studies that we're going to look at, and some of the questions that sort of linger in the back of our mind when we think about, well, is this possibly a long COVID situation? First, I want to hit about prevalence and recognition. So the question that I get asked whenever we're presenting is, are we seeing this in our care setting? How do we know that this is something that we're seeing? How do we distinguish this from anything else? And I want to start with looking at a dashboard that was created by our colleagues in the physical medicine and rehabilitation space, where they really took one of the earlier studies from JAMA, where they looked at the symptoms that persist in the 6 months following COVID, and the fact that up to 70% of people may experience the symptom, and 30% may still have, may actually have post-acute sequelae of COVID, in fitting in that definition that the World Health Organization has. So in doing that, and if we run it by 30% and look at all states, there is probably over 24 million cases of post-acute sequelae just throughout the country. When we break that down, because on this dashboard, you could even look down to your current state level. In the state of Florida, we probably have 1.7 million plus cases if we do that same formula. So it's really interesting when you're thinking about how often and how common this may be, from the fact that we still yet do not have good guidance on it, but we're probably seeing this in an everyday practice type of situation. When we think about the symptoms of post-acute sequelae of COVID, remember that just as we talked about before with the considerations of the pathophys and the cytokine storm that we see with an acute infection in the critical cases where multi-organ systems can be impacted, what we're seeing with post-acute sequelae of COVID is that multi-organ systems can be impacted. So you may have some people who complain about chronic headaches, persistent cough, shortness of breath with any activity. There is some new guidance from the American Academy of Cardiology, where they're really looking at the cardiology symptoms of long COVID and myocarditis and remodeling of the cardiac muscle to figure out and understand, is this what's causing these long-term symptoms? Other complications, to the point I made earlier, with partnering with Pamela Scarborough, we talked a lot about COVID skin and things that we were seeing following a COVID infection, such as persistence of rash or worsening of conditions like psoriasis and eczema, hair loss, and as well as worsening of wounds or development of wounds that are not responding to the treatment as we would have anticipated. There's also, in our population, from just looking around and talking to individuals and reviewing cases, we do see often reported a loss of appetite and some type of abdominal issues, such as either chronic nausea or chronic vomiting, gastroparesis. Recently, I've read a couple of studies where we're seeing that in some of the younger patients. I've not seen studies or anything indicating that we're seeing it in the older population, but it may be an issue and a source of the reason why we're seeing people not eat. So in thinking about just all of those symptoms, and looking at this and appreciating the fact that our patients may be experiencing one or more of these symptoms 3 to 6 months following their infection. One study revealed that some people are having this as many as 12 months following the infection. And in some cases that are being reviewed, the NIH study that's currently going on, they're following this out even longer than that, than those 12 months. So we don't know yet about the persistence of those symptoms, how long it lasts. And when looking at some of those long-term effects, I was reviewing this study, and it really showed an appreciation of how many areas can be impacted. And I know this is probably very hard to read, and I'm going to make sure you guys get this article. But the point of it is to really think about some of the things that we do see as far as laboratory changes. We may see a persistence of anemia, elevated white blood cell count and neutrophil count. There may be chronic lung changes that are occurring. And, I happen to think about those patients who are now on their third course of antibiotics for what we think is a recurrent pneumonia, when they now have pulmonary fibrosis, and some of those changes are really chronic. We are seeing changes with renal function, which I think was noted probably early in the pandemic. But even for people who had a mild case of COVID, sometimes we were seeing those elevated BUNs and creatinines. And so this study from Mayo really looked at how all of these different immune-mediated processes are being impacted, and what we're seeing when we're drawing blood work, and why we may be seeing it. So in thinking of all of that, the question that I want to really focus in on, and my priority is to really try to understand, is this long COVID when we're looking at these cases? And I've asked for a few cases to be sent my way. And I think anyone and everyone who did that, I think after reviewing some of these things, probably need even more cases to really review and understand what's going on. So the first case is a 94-year-old female long-term care resident who has a history of frailty and dementia. The dementia wasn't specified, but the patient has had multiple hospitalizations since her COVID diagnosis in August of 2021. She now has a persistent cough, worsening dysphagia, now with a PEG tube being placed, progressively worse muscle weakness. She's been treated twice for pneumonia in the past 6 months and has persistent abnormalities on her blood work. Those include leukocytosis, anemia, elevated BUN, and creatinine. And the question is this long COVID? And, feel free to take yourself off of mute. Feel free to put something in the chat so that I'm not just talking to myself. I will give you a little bit more background. As I stated, her white blood cell count and neutrophil counts remain elevated. She has anemia. At baseline, she's hypotensive with a systolic in the low hundreds. Denies any pain or shortness of breath on rest, but with any exertion, she does become short of breath. The question, and the reason why we thought that this was a post-COVID situation, was because there was a true, when we're looking at it, it wasn't as progressive as a decline that we would normally anticipate in a 94-year-old female. It was a true change in the way she was going. I believe what we noted from her positive COVID diagnosis, she didn't have a severe course. She wasn't intubated. She was able to come out of the hospital. But since then, I believe her first hospitalization being August 11th, she was hospitalized again in December, again in April. And every time, as we would anticipate, there was more declines in her function. And looking at it, again, the question became, is this possibly a post-acute sequelae of COVID. I was leaning towards yes. I would love to have anybody else who want to debate, but I was leaning towards yes with this situation because we did see such a dramatic change in her baseline. I don't know. If no one is willing to come off mute, I'm going to go to the next case. And this case is a 63-year-old female long-term care resident. She has a history of being HIV positive and has a history of frailty. She's been admitted several times to the hospital since her COVID diagnosis over 6 months ago. She is now with significant functional decline, worsening renal function. Per the write-up, she's been refusing to eat, been very apathetic, and has on her laboratory studies, she does have anemia. This caregiver did approach the family having extensive advanced care planning discussions. The family does not want to consider hospice care, but she is now with the diagnosis of adult failure to thrive. So I believe for her, she's been hospitalized multiple times within the same month, and now multiple times in the last 3 months, multiple times hospitalized. Her last hemoglobin was 7.2 in the ER. There was concerns of a GI bleed, and her condition just continued to worsen. White blood count remained elevated. BUN and creatinine were 33 and 1.9 respectively. And she was again treated for a potential pneumonia with Rocephin. And the question here, I think more details that came in was that she also had a weight loss of 7 pounds. I think this case is one in which we're seeing the worsening muscle weakness, the functional decline, the apathy, which I thought was really interesting because the CDC back, I believe, mid-year in 2021 added depression and apathy to its list of symptoms for long COVID. And so I think that it is interesting to see that here where the person just sort of is not interested in doing certain activities. That refusal to eat is something that we've seen. And I don't know if the source of that was in relation to the GI bleed. It's hard to figure out which comes first when reading a case, but it is interesting. So I was leaning towards a yes to this as well, because as with the other case, there was a change where it was a significant the caregiver described dramatic change where that person was no longer at their baseline. And we anticipate that people will have a change when they're in the hospital. I think we're all very familiar with that. But I wonder if this is something that we're seeing because of this issue. I did have a comment where the question is, is this more of a conspiracy? Like, is this more of a theory that we have that may not be in association with that? And I honestly don't know. I think that is interesting because we did see changes with after other viral infections, but we don't have enough guidance and enough studies showing if there's something that connects all of these cases that we're seeing. I don't know. Someone took themselves off on mute, and I don't know if they have a comment.
Hi, it's Carrie Crandall, and I have a comment in both regarding these two presentations. What I have found is that I do think, and also being a COVID patient, a post-COVID, and a long-term COVID patient, I'm not sure about defining something as long-term COVID versus defining it as a sequela of events that occurs directly related to the COVID, which is what I think it is, because it's such an inflammatory process. And I think that's what we're seeing and being validated more and more, a heart problem, tachycardia, dyspnea, tingling of your fingertips, GI issues, hair loss. These things are happening because the COVID is basically getting into the vasculature, the cell walls, and just going everywhere. And I think, especially as we know with aging, that aging and chronic disease, all you have to do is have one event going into the hospital. And that's when that person returns to their prior living situation, that they're not going to be the same, especially when they have so many underlying issues. And I think what happens, and like myself, I have both Lyme disease and Epstein-Barr, both years ago, 30, 40 years ago, that I never even thought for a minute might have been played any factor in getting COVID or getting all of these long-term effects. But it has. Those were factors that caused this, that have persisted and made all of my symptoms worse. So, but I think that's the point I wanted to make, was that I think these are definitely all wouldn't have occurred if that individual had COVID, be it a severe case requiring hospitalization and ICU, whether they're intubated or not, or an almost mild case.
Yeah.
It supports both. Thank you.
And no, I thank you for that, Carrie. And I think that's the reason why we want to see even more, get more information, see more cases to understand what could be happening. I will say this. I think the reason why the term long COVID was the term that was popularized by patients on social media. The formal term that we're comfortable using is the post-acute sequelae of COVID. And the reason why is because some of this may be complications of actually having the infection, and other of this is are symptoms that may be persistent. So it is, trying to capture that the umbrella, the whole umbrella, like everything under the umbrella. So that is why the term was revamped. I do agree with you. It is really difficult when you think that our people who are going out of the nursing home or going into the hospital are probably, we do know that they're going to come back a bit debilitated and different than what they had. So it is like, well, maybe this is all of the above kind of situation with some of these cases. Let me go to the next one because I thought this was interesting. This was an outpatient case. And this was a 78-year-old male who had a COVID infection 6 months ago. He refused vaccination. He was treated with monoclonal antibodies in the first 72 hours, but prior to that had refused to be vaccinated. He has a history of being status host renal transplant, history of spinal stenosis. And prior to COVID at baseline, he walked 1 to 2 miles daily. Currently, he has exertional dyspnea with exercise intolerance, muscle weakness, and severe low back pain. He's now receiving in-home physical therapy with incremental improvement. The case goes on to state that he has also complaints of abdominal discomfort with nausea at times, bloating at times. He also has a complaint of the chronic low back pain, which he's never had before, despite being diagnosed with spinal stenosis. That was a diagnosis made as he was being worked up for a renal transplant. And the question, again, is this potentially part of that post-acute sequelae of COVID? Is this long COVID? And I was leaning towards a yes to this one because it was a dramatic change. Per the write-up, the person can no longer tolerate going just out to to his mailbox to get his mail. And this was an individual who apparently walked around the neighborhood twice every day. We had another case of a 62-year-old female resident who has diabetes, history of strokes, chronic kidney disease, morbid obesity, hypertension, heart failure, COPD, and rheumatoid arthritis. She lives in the nursing home, was treated on the COVID unit in the facility until she went into acute respiratory failure. Upon discharge back to the facility, she continues to have shortness of breath, worsening renal function, and muscle weakness. As she's been hospitalized multiple times in the months following her COVID diagnosis. This person, and following up with the person who provided this case, this person was transitioned to hospice in the months following this. So this is an interesting one because she did have some significant findings upon discharge back to the facility that lingered, and she kept bouncing back and forth to the hospital before everyone was in agreement to transition her to hospice. Another case, 81-year-old female resident, a long-term care resident who has multiple comorbidities. At baseline, mild cognitive impairments, normal oral intake, was diagnosed with COVID with mild symptoms, did not have a fever or chest pain, but a month later had significant mental and functional decline, worsening renal function, poor oral intake, and that then persisted months after that when we checked in on this case. And that resident did end up being transitioned to hospice as well. And then I have one last case, and then if we have time, maybe we get some more individuals to weigh in as well. A 71-year-old male who's a homebound patient, which is interesting. He's morbidly obese, has COPD, chronic respiratory failure on oxygen, heart failure, sleep apnea, bilateral lower extremity lymphedema with wounds. He was fully vaccinated through the home vaccine program. And I don't know if we're all aware, but in the beginning of, once we had vaccinations in the state of Florida, early in that process, there was a way to get people vaccinated in their homes. So the Department of Health would, you would submit a request and the Department of Health would come out to the home and do the vaccinations. He wasn't boosted though, because and it's kind of unclear, but at that time they were not doing as many, and it was hard, even though the daughter didn't make the same request. He was never diagnosed with COVID, so this is a little interesting. Had several rapid tests that were negative during the Omicron wave, despite his entire family testing positive. So the daughter, the grandson who he lives with, his aide, all tested positive for COVID. And at that time, they couldn't do the PCR testing because there weren't enough tests being sent out. So they couldn't get those tested. He cannot leave the home. 3 months later, this patient had muscle weakness, sacral wound development, bilateral lower extremity wounds were getting worse, severe diarrhea requiring hospitalization for dehydration. After he was treated in the hospital, he was discharged to home and within 12 hours had another fall, which required 8 paramedics to lift him up. So it is interesting. This person had, we don't have any record of COVID, but potentially this person is seemingly having, fitting into that post-COVID type of diagnosis. And what makes, I think, this case even more fascinating for me is that that was during the time with that Omicron wave where a lot of the people were reporting that they were having negative rapids, and then the PCR would come back positive. There is a question about younger populations, and I'm glad you asked that, Jerry. Most of the studies which is probably one of the reasons why I'm always on the soapbox. Most of the studies that have been done around this, and most of the energy has been directed to the active population. So those young adults, 18 and then going up to age 64, the active people who are still in employment. To the exclusion of a bit of our population, as well as the pediatric population. Of late, there's been a lot of energy now being turned towards pediatrics because of the persistence and the mental health challenges that we're seeing in that population. So there's some more energy being directed towards pediatrics, but what we're seeing is that I've still not seen enough studies directed back to the nursing home population or the post-acute long-term care continuum for those individuals 65 and above. You know, I want to hit upon, and we're running into time. I want to hit upon questions about treatment. And then I think, Gary, I could hit upon your long COVID question as well with vaccinations. So just a level set, this was shared a few, maybe a week ago, a summary of preventative agents and therapeutics that we're seeing for COVID-19, where we can have people being treated beforehand with and I'm sorry, I have somebody. Is someone making a comment? Okay, so we've seen where we have the Evusheld and some other now oral antivirals that are out there for COVID. Currently, we do not have any recommendation to utilize those for the therapy for post-COVID. We do have a clinical trial that is ongoing by the NIH. It was supposed to be completed on April 1st. And so I'm hoping that we'll see a write-up about this come over the summer or early fall. So that is interesting because they are looking at utilizing monoclonal antibodies to treat post-acute COVID syndrome. What we do know is that the vaccines, when we've had some people who were vaccinated, we saw this study come out in January where we looked at individuals who were vaccinated with 2 shots, what happened when they got COVID. And we did see a decreased incidence of development of long COVID symptoms in that vaccinated population. This was, again, looked at as well, where we saw out of the British Medical Journal, we saw a reduced incidence of long COVID symptoms related to the administration of COVID vaccines. And looking at that 12-week period after, we did see that reduced incidence in that population of individuals who were vaccinated versus who were not. There's also been a lot of questions around, well, what do I treat with as far as vitamins? And so I want to just, level set about vitamins. I've always been in the vitamin D camp because my attendings beat it over my head in fellowship. But, in looking at what we are seeing, I know a lot of our patients are being discharged home on zinc and ascorbic acid, as well as vitamin D. This study looked at individuals with a active infection of COVID, and it was stopped early because they weren't seeing any significant differences between the 4 groups. So it was stopped. There I think will always be people who just believe in giving all the vitamins and supplements that we can, but there hasn't been any evidence to show that they have any long-term benefit. So I don't have any way to even support any supportive evidence saying that even in that post-COVID period, should we be supplementing? There's just not that evidence. The same with vitamin D. No significant association between the clinical outcomes of COVID-19 and vitamin D levels. But I think they're still studying this, and right now we just can't clinically recommend that. But when we're looking at the management of how do we approach this, the main points has been around you need a multidisciplinary team approach. You need to individualize care plans and ongoing support, which is nice to hear. What this has translated it to is a lot of COVID recovery centers, again, for that active population. And it is just interesting that we still haven't seen this being broadened to other populations. So we really do need to think about, okay, what does this look like for our long-term care residents, our post-acute residents? And a place where I turned to was into the physiatry literature. And this was an interesting study about looking at how should we be approaching acute COVID diagnoses and anticipating for individuals who may develop long-term sequelae of COVID. And in their recommendations, they proposed really thinking about the whole journey that person is going to have, and really designing rehabilitation interventions along that whole pathway. So from the way we prevent, and doing all of the safeties, but what happens when they're in that acute phase? What do we need to do? And as they're going into the post-acute rehabilitation phase, and now thinking about what long-term efforts do we need to have in place so that we can continue to rehab these individuals. There's also been another study that was published in the International Journal of Environmental Research and Public Health, where they're really thinking about how do we define those post-COVID symptoms, and thinking about that trajectory of that a person may take that journey. And in looking at that, that first phase would really be, or the initial onset is in the hospitalization, but then there's a transition phase where you may have symptoms that are potentially associated with COVID that are persisting. You have that acute post-COVID symptoms. So in thinking about if you were affected and you had a headache during your acute infection, maybe you're still having still having headaches. Maybe they persist after the 12th week and into that 24th week. So really trying to figure out, if we have this into phases, then how do we target treatments along those different phases? And then there was another study where we saw where they were thinking about how do we just do a different clinical approach and create a care pathway for individuals who may be experiencing these long haulers, long COVID, post-acute sequelae of COVID symptoms. And this was interesting because of the way they looked, and they really thought about starting all of this intervention even earlier. So at that 4-week mark after diagnosis or hospital discharge, they need to have additional screenings to identify if they have persistence of any symptoms. And if they do have persistence of symptoms, it then brings you to a different area of the algorithm where you are going to start implementing certain studies and tests to see where that person is at, sort of getting a different baseline for that individual earlier than what we've been seeing, and earlier than what World Health Organization has diagnosed as that defined as that time period for saying that someone has post-COVID sequelae. And I know I have a question in the chat I'm trying to see at the same time as present, but I think that if we're looking at this, we have to really figure out where would our members, our patients, fall into this algorithm, and how does this need to change for our long-term care and our post-acute and long-term care patients. the question that was posed to me, if a patient is diagnosed with long COVID, do they still continue with COVID vax regimen schedule? So that is a good question. If if they've not been vaccinated, there is evidence that they should go ahead and be vaccinated. And in those two studies I mentioned earlier, they're actually looking at what happens after you've been vaccinated if you were having the long COVID symptoms. The only I haven't seen any studies really talking about that period that have come out with more than like 20 people involved in it. So I don't have any clear guidance, just different case reports. I know that personally for us, when our daughter who had COVID toes, she's now 19, but when she had COVID, she did develop COVID toes, and that's sort of how my relationship with Pamela started. But when she was vaccinated, that did get better. But that is just one case, and so we do need to look at more information. There was a case where a gentleman who had nausea and vomiting following his COVID diagnosis. When he was vaccinated, he had even more nausea, vomiting, and ended up developing an ulcer following his vaccination. So, we need more evidence. We need more information to figure out what that is. I would err on the side of protection and having that person vaccinated. In the minutes remaining, and I don't know if there are other questions that I might have missed, but in the minutes remaining, I do want to talk about coding again, because what we're looking at and what we're seeing is how we are capturing and documenting this information. And the one thing I want to make sure everybody is aware, hopefully at this point, is that there is a post-COVID-19 condition, ICD-10 code U09.9, which was added by the World Health Organization early in 2021. It was accepted by us in March of 2021 and implemented on October 1st of 2021. So you could be utilizing this code if you suspect that somebody may have post-acute sequelae of COVID or any other of the terms that you feel more comfortable using. They all roll up into this one code. Interestingly enough, any post-COVID complication also would roll up into this one code as well. And the thing when you think about the symptoms, if you are seeing a symptom, you code that symptom first. So if I saw someone who had persistent fatigue, I would code fatigue, and then I would code the post-COVID condition secondarily. So it is very important to do that. I know some EMRs, when talking to people, they won't even let you put U09.9 as a primary code. It has to be in association with something else, which is probably the safer way to get it actually coded and captured and not kicked back to you. That example then being, so you have fatigue 2 months after COVID infection, you're coding the ICD-10 code for fatigue, then you will code the post-COVID condition code. And I think it's very important for us to, if you suspect it, to start coding it. We need to start capturing information both on our end, where we're doing what we're doing now and exchanging information and talking through cases, but also on CMS and any other payers in where we're looking at this, because we really do need to think about how we approach this for our population. And I say all of that, giving, I think in the presentation, I gave more examples, but I say all of that because I really do feel like we need to answer this call to action. There was a study that was given, that not so much a study, but a commentary in, I believe it was March Journal of American Geriatric Society, where there was I thought it was really interesting and fascinating, because this is how I was feeling, where we felt like the nursing home population is once again being forgotten about. in thinking about how we are targeting post-acute sequelae of COVID. There are those, as I stated before, COVID recovery centers that are really being developed for more active people. So people who are currently employed, people who are not in that Medicare age population. Leaving off both ends of the age pool, so both the older and the younger. And now we're seeing them come back and talk about pediatrics, but still we haven't seen the uptick of us having these conversations in our own literature, and really identifying and developing guidance for our own population. So what I think we should be doing now is really understanding what is our residence baseline, having that truly documented, documenting that every time you're seeing the person as part of whatever note you're doing, but having a high suspicion for post-COVID conditions, because these findings, especially if they're so dramatic and there's a dramatic change in condition, I know the trigger response is, oh, it has to be a UTI, something else is going on, let me start empiric antibiotics. For most of the people, we've always sort of preached against doing that, but we're seeing it now where we're utilizing more antibiotics, we are utilizing more psychotropics, and we really need to think about what is it we're seeing so that we can develop better approaches towards it, and then document that correctly, and please capture the coding appropriately. And my ask is that, even I would love to see even more cases. I would love to have sessions where we're sitting on and reviewing cases and making a plan to write this up so that we have not only a voice, but really understand the interest, and that no one else is going to speak towards our own interests and our own specialty. So we need to own that space and write about what we're seeing. And with that, I am going to open it up for questions. Sorry, I was talking real fast. Are there any questions, any comments? Dr. Kaplan?
Yeah, Diane, can you hear me?
Yes, we can.
Let's see, I can get on. So in today's AMDA weekly Pulse report, at the bottom where they have the news and news analysis, I don't know if anybody had seen this, but it was interesting. They had an article with a couple, these are anecdotal cases, just a few, 2 to 3 positive responses to Paxlovid for long COVID symptoms. Both cases were in their 40s, and both basically had significant symptoms of long COVID, and just for whatever reason ended up taking the therapy and noted some dramatic improvement. Of course, this hasn't been looked at across the board, et cetera. There is the ongoing question of whether antiviral treatment not only will prevent severe COVID, but will it actually prevent onset of long COVID? So that's a question that lingers out there as well. So just some food for thought. Thank you for a great presentation, great overview. Thanks.
Thank you. I think that is where a lot of good findings are going to be, because I'm really hopeful about some of the one trial that the NIH is doing with monoclonal antibodies, but it would be interesting to see if there is if we get really strong data around the oral antivirals. I'm really hopeful about that. And I think I think the question about Paxlovid rebound and acute COVID treatment, I know we've heard about a couple of those cases. I do not have enough insight or information to share it. I don't know if we have any pharmacists on the call, but Glenn, we could definitely take that question away to see if we can answer it for you. From Catherine, have you seen the effects of PASC on your staff who've been affected? I have. I don't know if anyone else wants to can speak to this, but I've talked to individuals in the HR departments and spoken to friends at facilities where we've seen more individuals not be able to do not be able to complete the task because of some issue that they're having that probably falls under post-acute sequelae of COVID. I don't know if we know the full impact of that, but I will say that, you know, if you put post-acute sequelae of COVID into the CDC's website, what you're going to get is all the pointers about how to file for disability. This is a big deal in the active population. We are seeing a lot of people, and we're anticipating seeing more people file for disability because of post-acute sequelae of COVID. So I do think it's probably impacting our workforce. Carrie, you have a question?
Well, you were talking about what do we do now with long COVID and how do we in the nursing centers treat that, or what do we do with it? And what I would have to say, and as difficult as it is, because staffing is a major issue all by itself, but as a long-term COVID patient, I can tell you a short-term inpatient in-house rehab is not going to do it, because the sequela that comes up is so long. And the fatigue, the shortness of breath, the muscle weakness, the panic attacks, everything that goes along with it doesn't happen quickly. And so we need to empower what we used to call restorative nursing and have programs that after a rehab, acute post-hospital rehab, a multidisciplinary thing with therapy, activities, and nursing, because it takes a long time to get your breath back and to overcome the panic fears. And, you know, I can just tell you that when I work out now, 9 months on Sunday from my hospitalization, it's only been 6 weeks since I've been without oxygen working out.
Wow.
So we have to change how we do things in rehab.
Yes, I sorry for the echo. I 100% agree with you, Carrie. I think it's going to take us, and that's one of the reasons why we need to start documenting, writing this up, and really getting a full appreciation of how this is impacting our care setting. I think it's going to take us doing these things, because if we're going to change how we're working, we also need to understand the fact that we're getting paid by the states and the federal government, and we need to push back on certain things, because it may take a longer course of rehabilitation for an individual. It may, those 21 days may not be enough.
No.
Yeah.
And that's the most important thing is that I can share is that, as much as the words tiny steps, slow but steady, and patience, not progress, those were not words in my vocabulary ever. But, what I can say is that this really is something, if we're going to prevent the people eventually from going to hospice, maybe too early or being too impatient that rehab, they can't quite make it in rehab. It just takes a long time, but it works.
Well, thank you. Thank you, everyone, for joining us. And if you have any questions, let us know. I think I've saved the chat so we could address any questions that we didn't address on the call, and the presentation as well as the articles highlighted will be posted. So thank you, everyone.